Okay, so now the bimanual examination. There's one crucial thing that I forgot to put on here. See if you can think of why, what that is. Why did I do it? Well, maybe because I'm a dumbass, maybe because I'm in a hurry, but I will put it on these blobs of press stick at the end. Let's see if you can work out what I forgot. So, retained products of conception. If septic, this woman's going to have a very tender, bulky uterus. They're not going to be any adnexal masses because the pathology is in the uterus, remember. If not septic, she might have a mildly tender, because remember the tenderness isn't from your hand, it's from contractions. Mildly tender, it's going to be bulky, so you're going to be able to feel the uterus quite easily because this has been a pregnant uterus. So it's going to be enlarged and easily palpable. Then your ectopic is going to be excruciatingly tender bimanual examination. The uterus, so you might not even be able to complete this examination, or this one for that matter, if she's acutely tender, but you need to try so that you can get to the bottom of what's going on. So she will have a normal size uterus as compared to this patient who's definitely going to have a palpable bulky uterus. She's going to have severe cervical excitation tenderness. What is the mechanism of that? Well, let's say this is the cervix, and no, how am I going to illustrate? There's the cervix, and here are the tubes. When you are doing a bimanual, can you see my hands? Yes. When you are doing a bimanual and you move the cervix, you move the tubes along with the cervix, and that causes a lot of irritation and pain if the tube has a problem. So if the tube has got a ruptured ectopic in it, lots of severe cervical excitation tenderness, not because the pathology is cervical, but because you're moving the tubes, that whole ligamentous structure that keeps the tubes and the uterus kind of attached to each other. There's going to be severe unilateral, so one-sided adnexal tenderness, and there is not going to be an adnexal mass. Ectopics rupture the tube very early on in a pregnancy, so it's not something that you are going to be able to palpate, okay, on your bimanual. Moving on to our PID grade 3/4. So again, extremely tender. It's going to be a normal uterus, which may be tender, but the tenderness is normally confined to the anatomical site of the problem. So that is either unilateral or sometimes bilateral adnexal tenderness, and you may be able to feel an adnexal mass, which would be the tubo-ovarian complex. Okay, if you don't feel that, it doesn't mean that your clinical suspicion is necessarily wrong, but you may be able to feel a mass there. And in this patient, the examination is going to be a bit tender, but definitely not as tender as these two. There's going to be tenderness focused to the side of the pathology, so that is where, whichever side the torsion has happened. And remember that I said that torsion only happens in the presence of an ovarian cyst or mass of some kind. So you might be able to feel that ovarian enlargement over there. Right, so now what did I forget to talk about on the bimanual, which is so crucial and can really help you with your differential? I hope you're screaming at the video that I forgot to tell you about the os. So in the retained products of conception, is the os going to be open or closed? I hope you said os open. In an ectopic, open or closed? Closed. PID, closed. Torsion, closed. So this is a very nice differentiator. This patient is going to have an open os. These patients are all going to have a closed os. Right, so our next stop on this train of gynae emergencies is going to be what side room test would you do and what results are you likely to have. And after that is going to be management. Right, I'll be back.